Good morning and welcome to everyone. Welcome to a presentation by MedTech Momentum, which is the premier marketing and branding firm in orthopedics, Comendia Capital, which is an outstanding group of life science merchant bankers, and Orthopedics This Week. Our masterclass today is the 6 orthopedic trends you cannot ignore. And we're honored today to have with us in our masterclass a truly world-class faculty. My name is Robin Young. I'm the publisher of Orthopedics This Week, and I'll serve as today's moderator. Today's masterclass will be a panel discussion with each faculty member giving a 5-minute overview of their subject matter, and then these experts are available for you to ask questions as they are presenting and after they present. We have approximately 400 participants in our virtual classroom today. Okay, let's get started. One orthopedic trend we cannot ignore is, of course, the effect of COVID-19. The first forecasts of the effect of COVID-19 on orthopedic procedures began to drift out of the Wall Street analyst shops about 10 days ago. The consensus currently, that's before companies like Zimmer and Stryker and DePuy report their numbers. And those numbers, by the way, will be coming in about 2 or 3 weeks. The initial forecasts are that orthopedic procedures, most of which are considered to be elective, will decline 23 to 28% for the full year. Now, the real story is actually what's happening by quarter. The analysts are saying they think the first quarter procedure volumes will be around 90% of normal. By the second quarter, they are thinking that it'll be around 30% of normal. And by the third quarter, 60%. And by the fourth quarter, and this is very important, it'll be over 100, more like 120% or more. In fact, when I'm reading in the reports that I get, they think that the beds start to free up for the elective procedures near the end of July and build through August and become a majority by September. And they're thinking that this is going to be kind of a rolling recovery across the country by state. And don't be surprised if you find the state of Washington, which had been a hotspot, will be one of the first places that gets back to whatever normal becomes after all of this. The main takeaway from these forecasts is, first of all, they're forecasts. Second, we're going to get better numbers in about 3 weeks. But it's important for everybody, all suppliers, to use this downtime. Of course, keep your people as engaged as possible, but ramp up your communications with your doctors. Use this time to increase your communications, your training sessions, your product discussions, your upgrades. If you spend this downtime doing 120% of your time working with your customers and your physicians, when the surge of surgeries happens, which it will come, those physicians hopefully will have your company, your products top of mind because you invested the time now being in touch with them and using this period of time. So I have a question for our participants. And you're going to get a poll coming to you. And so if you would answer, how many of you are working from home right now? So click yes if you're working from home and no if you're not. And we'll see how many of you are. Okay, Carolina, how are we doing so far? People getting some numbers? %91 are working from home. Okay, let me do one last question, then we're going to turn it over to our faculty. When you think of this COVID-19 crisis, when do you think it'll ease up enough to free up beds for the hip, knee, and the other elective surgeries? Just click on a month that you think strikes you as the most likely time when this will free up. I'd be curious to see what everybody thinks, what sort of the consensus might be at this stage. And just a reminder, other countries and other places that have gone through this have roughly a 3-month cycle from the beginning to when the curve, when they have either no new patients or just 1 or 2 new patients. Okay, so how are we doing, Carolina? Wow, that's interesting. Okay, 32%, the most of you say July. All right, and we have, so if we take June and July, that's over half. Well, hope. So let's begin with our faculty presentations, starting with the regulatory environment. Over the past couple of years, the regulatory environment has been changing in ways that often seem confusing and overly burdensome. We are really lucky to have with us who I consider to be the leading regulatory expert in the country, Glenn Steigman, who's the Senior Vice President at MICRA. Glenn?
Thanks, Robin. I think probably the bulk of my talk today will be surrounding what you opened up with, the effect of the regulatory environment, given the situation we're all living in. First, from the regulatory standpoint, meaning FDA, US FDA, it's still all systems go. We've not seen any impact of COVID-19 on submissions. The document mail center or document control center is still open. They're still processing documents. The turnaround time, if it's due, some of the turnaround times, if it's due after mid-April, you're seeing differences in responses. But other than that, we've seen actually an uptick. And we've told all our clients to actually be a little more aggressive on submissions, meaning send them in as soon as you can, because you don't know when the situation is going to change. I believe as soon as someone does test positive in and around the FDA, things will probably shut down. The bigger impact that we're seeing is dealing with the clinical studies, all the INDs, all the IDs that we're running, the other companies are running. The big impact is there, just like you said, the procedures, the elective procedures are halted. And this has huge impacts on the IDs. Surgeons can't implant new devices, investigational devices, and patients aren't coming back. Monitors can't get into hospitals. And the FDA has been pretty flexible on a lot of these things. In other words, when an endpoint is coming due, a 12-month, 24-month, whatever it may be, they're allowing some flexibility in those patients coming back. What we've done at MICRA is really create almost a virtual environment, create remote monitoring scenarios so no monitors have to go to hospitals. And I imagine every CRO should be or has been doing this, or every company has been doing this, not to expose their staff and monitors, but also setting up virtual studies so that all of the PROs, the patient-reported outcomes, are taken at home by patients. Even neuro assessments where patients need the help of a physician or a clinical monitor, creating those that can be done virtually over Zoom meetings like this or whatever it may be. The one caveat obviously is radiographic assessments and trying to fulfill that requirement by FDA. And when you talk about make or break orthopedics or maybe any therapeutic area over the next decade, I'm looking at this particular scenario from just what you polled, the next 3-month to 1 year time frame, and understanding the impact it's going to have on these studies and the approvability of new innovations. If studies are ending right about now, how are they going to get these patients back to do that final endpoint? How is that going to affect approvability? But on the flip side, on the good part of this is, we're all resorting to creative ways to work from home, have meetings, have things, have series like this. And I believe the FDA and the industry in general are going to start creating clinical studies that are almost virtual, where we have many of the time points where the patient never enters the hospital or the physician's office. So, we're hoping that, this is going to end up with a good trend. This most crisis and pandemics end, people start thinking outside the box to fix issues that have been in front of them forever.
That is terrific. Participants, attendees, I hope you're thinking of your questions for Glenn. Glenn, that was a wonderful outline. Really well done. Our next speaker is going to cover robotics. This seems to be an area of a lot of investment from the major companies, certainly starting with Stryker, but moving through all the majors, DePuy, Medtronic, and so forth. Chris is the CEO of Harmonic Bionics and is one of our experts in robotics. Chris, you're up.
Thank you, Robin. So I'd like to start with two questions, one on the current situation in robotics and robotic-assisted surgery, and then your own forecast, where you think it's going. So Carolina, could you put polling question one up now? What percentage of surgeries are being done robotically, robotic assistance, across all specialties?
The top result is 5 to 25%. 50
okay, it's actually less when you look at all specialties. So very good. I mean, it is. We've only scratched the surface. So this is after 20 years of soft tissue work with Intuitive, and the last 10 years of trying to advance robotics even in orthopedics. So it's less. So let's look at them very quickly. What's looking forward? Where do you think in orthopedics that percentage is going to be in 10 years? So could you put that up, Carolina? Again, no right or wrong answer here. It's just interesting to hear from all the attendees where you think it's heading and at what pace. So what we'll do is, Caroline, you can get the answers, and when I finish, we'll see what the actual spread was. So what I will do is I'm going to share a little bit here. All right. So what we'll talk about is the trends, going forward, which you have to be aware of. Especially with robotics and orthopedics. My background's been about 20 years in robotics, both in the soft tissue and hard tissue space. So I'm deeply biased, of course, and then I'm currently in a bionics company in the space as well. So what is robotics? Very quickly, we don't have to go into the deep definition, but you're talking about anything with perception control, sensory feedback, information processing. That's one that a lot of people overlook. The device, performs something that's complicated, and it does it in an automatic fashion, probably a lot quicker than we do it. And it can handle repetitive tasks. All right, so what's the trend? I liken to, where has ortho been historically, and where is ortho going? So if you look at, the past, it's a bit of a Wild West. It was reactive to problems, a lot of preference in it. You can do what you want, you shoot from the hip. And there was significant variation in procedures. You could walk in, whether it be a knee, a hip, an L4, L5 fusion, walk into 10 of them and see, from a process standpoint, 10 different procedures. Now, where's it going, and where will robotics play into that is more into a process optimization. If you're looking at it from a systems engineering process standpoint, you need to control the variation in a process. Standardization, automation helps that. Getting to more precision, more predictability, more reproducibility. I took some photos this is actually from the same show. I don't know if you watch Westworld or not, but it's an interesting combination of the advanced scientific robotics with the Old West. And nice dichotomy there. But as they make these robots, which are of course more humanoid, they do so in an automated fashion. So you have more of those industrial type robots making more intense robots. That's not 10 years from now. That's maybe 100, but not 10. So quickly, I'm going to give you two ways I think you should be thinking about robotics and ortho. Very quickly, I want you to think about it from a process standpoint, and then also location standpoint. So when you look at the process, you go through your SIPOC, your suppliers, your input, your process, your output, and your customer. So where we have been with robotics so far, the players that have been mentioned, Mako, Mazor, Rosa, Excelsius, Navio, Think, all in the room, all doing specific tasks. I think in the future, you're going to see more of those doing specific tasks as well, but you also see an integration of capabilities where some of these will jump from the current specialty within ortho that they're in into others. If they're in knee and hip, they may be going to spine. If they're in spine, they'll go to knee, hip, shoulder. But also what I want you to do is open your mind up and think about the other aspects of the process where you will see robotics. And if you're not aware of that in your strategy and your planning, you could lose out. You're going to see robotics hit in the logistics standpoint. The Amazons of the world use robots left and right in their warehouses. You'll see that more in hospitals. You'll see industrial companies that are currently doing industrial robots crossing over into healthcare. It's already happened. A lot of the German companies are doing it. And you'll see transportation robots working in hospitals, around hospitals. In robotics and imaging and diagnostics, you'll see more of that information processing, the predictive analytics, the assessment before you even go into a case or a procedure, the diagnosis. And on the back end, you'll see bionics in the recovery after ortho, and you'll see bionics in the predictive analytics of how good you did in that procedure and how well you may do into the future. So you'll see these different changes in the next 10 years as robots enter the entire process of orthopedic care. And then the places where robots will be. We've been in the box. The box has been the acute care hospital. In fact, it's been the OR within the acute care hospital. You've seen some of the robots already get into the ambulatory surgery centers, but you will see them in urgent care, imaging, specialty clinics, physician offices, fitness centers, wellness centers, retail pharmacy. So you got to think outside of the physical box. We're in an environment now where we're seeing we are susceptible when we have mass casualty. It's a slow rolling mass casualty event. But we're susceptible because we do everything in the same spot. This will also push to, all right, do we need to do ortho procedures in that same spot that we do mass casualty handling? We'll do it in other sites as well. And additionally, on the downstream, you have robots, they're in rehab now and box, and they'll continue. A lot of it's been on the stroke or different conditions, but I believe you'll see the advent of those into orthopedics. And then also you'll see them back into again, on the downstream, physician offices, wellness centers, fitness centers, and the home. You'll definitely see home devices for post-orthopedic care. And I don't think it's a crazy idea to think that the footprint out there of the LA Fitnesses and all the fitness centers that have a lot of space could easily put in after action, after orthopedic care centers. So I do believe that will be an advent you'll see as robotics gets out of its current box in ortho, which is the OR, and into other parts of the process and also into other spaces in care. So with that being said, I want you to think upstream and downstream in the process. That's where you're going to see it. Don't just think about what you're currently doing, where your product currently is. You have to think up and downstream in order to understand what the implications could be on the way you serve and what you do with your product. And think before and after the hospital as well. So with that being said, so Carolina, what was the final on the numbers? What do we think? Okay,
very interesting.
So some of you believe, yeah, that we're going to be on the path of what soft tissue has done in 20 years, and others believe will be better. I'll tell you my personal opinion. I think robotics and orthopedics will advance at a much faster level than it did in soft tissue.
All right. Thank you, Chris, very much. That was terrific. Moving from the hardware to, in effect, the software, regenerative medicine, including the use of live cells, has the potential to give us new and potentially disruptive treatments. To help us understand the state of the union, we are just delighted to have Scott Bruder, CEO of Bruder Consulting and Venture Group, giving us the state of the union for regenerative medicine. Scott?
Fantastic, Robin. Thank you for the opportunity. And I'm sorry that I'm not able to be with everybody in Orlando because we all look forward all year to the Academy meeting. And unfortunately, we're in this situation. But I'm glad people are joining today. So thank you. And what I have in 5 quick slides and 2 questions is to sort of frame the future around this field, orthobiologics, tissue regeneration more broadly, and the growing need for evidence, the growing need for evidence-based medicine to succeed here. I'll start with this slide, which is really the work from my good friends over at OrthoWorld showing the 2018 results on sales. Top line worldwide sales is $51 billion for orthopedics overall. Importantly, 10% of that, or $5 billion, is in this orthobiologics market, which is a wide variety of biomaterials, cell-based therapies, PRP, growth factors. But what's interesting is that in that in that period, and OrthoWorld will have their 2019 data available later this spring, you can see the total market grew 3.5%, but orthobiologics was flat. And the big part of that was the loss of the viscosupplementation, the reduction of those units and those procedures, mostly, I think, in part because of Academy's position and insurance that's taking a harder look. But what's really interesting here is that you see in this 39% segment here, this is 200 firms. And if you look at that at $2 billion, it's an average of $10 million a firm. So there's lots and lots of firms out there, 200, that are selling on average just $10 million of product. When you break out this $5 billion, you see, in fact, that it lays out this way, where the bone field, the bone products are about 60%. Here looking at 2020, this is an estimate, but bone is 60%. The light blue is HA, or hyaluronic acid viscosupplementation, and MACI, or cartilage repair. Most of this is that viscosupplementation. And in the center here, this thin segment is the soft tissue. And this is where the market is least mature, but also represents some significant opportunities. So now, Katerina, can we go to the first question, which is, for those of you on the phone, you can't see it, but I'll just read it out loud. Are you currently selling, or do you have plans to sell orthobiologic products over the next 5 years? Choices: we're selling now and have plans to launch more, selling now but have no plans to launch more, we're not currently selling but have plans to launch, or not currently selling and have no plans to launch. This is, I think, a bit of a litmus test for how people are feeling about the environment and what the opportunity looks like. Catherine, do we have a decent number of replies yet that we can put up there? If it's going to be delayed, I'll just continue and we can maybe give these results at the end. So I think, since I don't see it, we'll talk about those. Oh, here we go. Okay, that's interesting. So 40% not selling and not planning. Another almost 40% selling now and have plans to do new products. Very few that are selling now but have no plans to launch new products, and some that are not selling. So the 37, so it's about 60% can plan to continue to sell products. Thank you very much. That's really interesting. We know that there's dedicated hardware companies that have no intention of selling biologic products. That's just fine. Well, why is that? Part of the reason is, I'll show this example here of 2020 coverage on a variety of these biologic tissue repair and regeneration products. You can see from infused BMP2 to the various demineralized bone products or allograft products, including next on the list would be articular cartilage repair with culture expanded chondrocytes, and then all of these other products, platelet-rich plasma, allogeneic bone graft or MSC therapies. By the way, we should all be very clear, there are no stem cell products that are approved in any condition of musculoskeletal tissue repair or regeneration. That's just, it's not arguable. The agency is very clear about that. They put out public messages. And the reason this is relevant here on this slide is whether all of these products that are non-covered, the reason they're non-covered is they lack sufficient evidence, and they also lack sufficient code. So they neither have the important triad of coding, coverage, and payment. And so what's interesting is that while many of these products on the bottom half of the slide are relatively easily cleared into the market, they don't have reimbursement status that's favorable. So they wind up being paid for out of pocket. And in fact, many of these, if any of them at all, to receive a specific reimbursement, have years of work ahead of them. And so the dichotomy here is those that invest heavily in a PMA or a BLA, which could cost $30 to $100 million or more, they're going to be the ones that have the opportunity for reimbursement. So I'm setting the landscape. I'm trying to provide some of the guardrails, and identify the importance of evidence-based medicine if you want to get reimbursed. At the same time, the authorities are stepping up their surveillance here, and you've got FDA who, on the heels of the 2017 guidance around HCTPs, which deal with things like cell therapy and PRP and bone marrow and amniotic tissue, which are different than recombinant growth factors, you've got them issuing nearly 50 warning letters already and telling the community that in November of 2020, this discretionary period is going to be over. You also have the FTC, who is levying fines, multi-million-dollar fines on physicians and practices for advertising improperly and making statements and claims on their websites about things that these, quote, stem cells do, or things that PRP does, or things that amniotic tissue does, for which there are no claims and there's no substantial evidence. And so that's hopefully creating a little rebound effect where people are coming back into appropriate behavior. And then, of course, you've got the societies themselves, whether it's AAOS or ISPRM or the various medical boards that influence not just physicians, but they also influence OEM manufacturers and industry people like I think are most represented on this call today. And so my last slide before we go to the last question is, what does this mean for new product targets? Well, I have these conclusions. Bone graft is a very mature market. If you're going to do something new to grow that $3 billion market, it's going to have something that is based on evidence, efficacy, value, profitability. So bone is a very mature market, but articular cartilage, which has been regarded as the holy grail, it's still missing something that is really a winner. So we see the folks at Vericel growing substantially, and I'll say Vericel is not one of my client partners. We have about 20 client partners, but I didn't go through a disclosure because I'm not talking about any of their company specific products. But this still remains the holy grail. Meniscal repair. We've seen a product go, fight the legal battle and eventually get into market, but it's not a blockbuster. And so there are a lot of these devices out there. There's some that are in development and some going through the agency now. This represents an important product opportunity, as does ACL repair. Now, obviously, there's a whole littering of skeletons, no pun intended, on the roadside here. But if you can develop a biomaterial with proper mechanics, there's a big opportunity. I think one of the largest opportunities is IV disc repair and regeneration, or prevention of degeneration. This is most likely an HCTP, a drug, or a combination product, but still years away. And my last comment here is that the FDA pathway, as I've already alluded to, these 510K, there are ways to get products cleared into the 510K highway, so to speak, and that get you market presence. But in the absence of clinical data, the challenge is going to be reimbursement. And so let me close with, I'll stop the share and come back to the last question that I asked Katerina to put together. If you could post that one, which is based on your understanding of the evolving FDA rules and market forces, not just the FDA rules, what actions are you going to take over the next 5 years? So business as usual. I'm cavalier and not concerned about FDA or FTC compliance. There's a lot of people out there, and I go to meetings and I talk about the compliance issues, and I see docs, clinicians just saying, there's 30,000 orthopedic surgeons, let them get me. I don't subscribe to that view, but we'll see how people on the company side do. We'll bring our risky practice into compliance, but still market aggressively. C, we're committed to collecting clinical data to support reimbursement. Or D, the hurdles of compliance and data generation are just too high, so we're not going to continue to invest. Love to see the results as soon as they're available.
I have to say, Scott, those are terrific questions. Thank you.
Thank you. I love the answer. I love this answer because
Wow.
it makes me say people are getting the message. Sorry, almost 80% said we're committed to collecting clinical data to support reimbursement. So that's fantastic. I think it's fun. It's fun to see that 5% are still so cavalier they don't give a damn. They're just going to do business as usual, and that fewer, it's a small portion, and so I'm delighted to see this. There are challenges. Glenn will tell you the same thing. There's challenges with collecting good data, but I'm delighted to see that people are committed. So with that, thanks for the opportunity, and look forward to the rest of the conversation.
Thank you so much, Scott. That was really informative. Our next subject is MIS, and the scope of MIS in orthopedics is already very large. It's increasing. This is the fastest growing sector. But are there some MIS markets we are missing? Can we benefit from looking at minimally invasive surgery in a broader context? To help us tackle that question is a speaker that I am just so excited to hear. He's Earl Fender. He's the third, by the way, J&J alumnus on this call. Past president of Vertiflex, and he has a very interesting case study to share and thoughts about those questions. Earl?
Thanks, Robin. Good to be with you guys. So I want to use Vertiflex, the company that I'm just about to leave, as a case study. Vertiflex is a 14-year-old company that's been venture-backed and has as its main therapy an MIS interspinous spacer. This is a market that has about 6 million patients in the United States who have the same symptoms as would overlay our technology. And the hallmark of the company has been an 8-year, $50 million IDE study, which Glenn Steidman happily helped us turn into a PMA. And then Vertiflex was acquired by Boston Scientific this past June. So there are a couple of takeaways that I would like you to get from this brief talk. First, that MIS technologies or products can indeed expand provider specialties, expand your customer base. The second thing is that companies like ours have the responsibility to ensure that all providers, regardless of who they are, what type of specialty they are in the best position and are the best qualified to ensure that patient interests are well taken care of. And then anytime you expand a provider base, a customer base, you might run into some politics. And so I'll talk for a moment about how one might think about mitigating those. So Vertiflex, here's the story of Vertiflex. It was intended to be, it's 14 years old, I came 12 years ago, and it was intended to be an MIS spine company. I ran J&J's DePuy spine business. I'm a spine guy. But we started the first year of our IDE enrollment, and as I said, it was an 8-year trial. Enrollment took 3.5 years, and it was a non-inferiority trial against X-Stop, which was the only approved device at the time, and it had a high revenue level. And about 1 year into enrollment, X-Stop sales started to decline quickly. And the feedback that I was getting from spine buddies around the country and some of the spine surgeons in our IDE trial was that we could bring this to market, but they would never use it. And I thought, I'm about to do the most expensive large trial ever done and bring to market a product the world doesn't want anymore. And so I started to think and scramble. And I started to think about interventional pain management docs. These are the guys that are doing spinal cord stims and ablation and then drug pumps and so forth. And while those don't bear any resemblance to stenosis, technically, from point of care, ASCs, for example, there was a lot of similarity. So I brought about 40 of those guys to our home office and started to assess whether they could do this type of therapy that was the Vertiflex procedure. Long story short, they could. We put them in the IDE trial, and lo and behold, their results for both safety and efficacy were the same at the end of the trial. And I knew that if spine surgeons weren't going to end up being my customer, I would have one that would. Almost immediately, we got our approval, PMA approval in 2015 and Category 1 reimbursement same year. In 2016, we started to commercialize almost exclusively with pain docs, and immediately spine surgeons pushed back. There's some entertaining stories I could tell you, but let's just say that for the better part of a year, I had quite the battles on my hand to calm that down. But what I said to the spine surgeons We had spent $170 million to bring this technology to market. The data was extraordinary, and patients needed this. And I wasn't going to leave it on the shelf. And if spine surgeons weren't going to use it, I had to find a different way. Pain management was one of those ways. Now, about 20% of our business today comes from spine surgeons, and that's a growing percentage. That's good. But we carefully select these interventional pain docs. They're fellowship trained. They are not the so-called needle jockeys. They are doing these other procedures. And so we've selected them carefully. We've trained them carefully. And we have fostered collaboration with spine surgeons in the marketplace, in the individual communities. This generally is a different patient, an earlier stage patient, than the one the spine surgeon would treat with laminectomy or fusion. And once that is clear, the political battles, the turf wars go down somewhat. But in fact, it's not a lot different than cardiology and interventional cardiology of many years ago. The data matters. I mentioned that we have 5-year IDE data, 80% success rate, successes with 90% patient satisfaction. We've chosen to do 2 registries tracking 4,000 patients, most of that commercially done by pain doctors, with the same or better outcomes, because you learn how to use these technologies over time. So the outcomes in the registries are actually better, and because they're doing mostly, being done mostly by pain docs, it's taken away some of that stigma. I think that, I could go on about this, but what I would say is that having 2 groups of customers on one hand is challenging. It's important. We take the responsibility to make sure the pain doctors are well-trained and are competent to do MIS spine surgery. But note that it also expanded the number of acquisition targets. I guess we could have been bought by a traditional spine company, but who would have thought Boston Scientific would have bought a spine company? And yet, this fits wonderfully into their pain management franchise, which fits into the neuromodulation segment of Boston's business. And I think this is really good for patients. And so it will give patients more access. And with the resources of a Boston Scientific, patients will be better cared for, lots of marketing to bring them into sites of care and so forth. So I think that's our story, and I'll stop for now. But Robin, I thank you very much for the willingness to hear this story, and maybe it'll shed some light on some of your own businesses.
Earl, I think you just inspired a whole lot of people with that story. The mark of a true entrepreneur is when you hit that brick wall, you go over it, under it, around it, through it, whatever you got to do, and that's what you did. And I have to say, it's just an inspiring and amazing story. Thank you. Sometimes a technology comes into our industry that kind of looks like an ugly duckling, and you kind of ignore it a while, and slowly it builds, and before you know it, you turn around and it's changing the industry, how products are designed, how they're used, and it's opening up new doors, new possibilities to improve surgeries. 3D printing is one of those technologies, and we are so fortunate to have one of the brightest guys who's been around and seen most everything speak to us about 3D printing, and that's John Viscogliosi, not only a principal at Viscogliosi Brothers, but the CEO of one of the more dynamic companies, Sentinel Spine. John?
Thanks, Robin, for the introduction. That will be hard to follow, and all of the presentations have been great so far. One prevailing point that has come across in everybody's presentation is that data matters. Data is important, and clinical results are very, very important, as showed in Scott's poll of everyone of the importance of that. And I can tell you, in speaking with surgeons on a consistent, almost on a daily basis, is clinical results, long-term clinical results, and evidence is key. And that really falls into what I want to speak about with 3D printing. Is 3D, what really is 3D printing in comparison to current manufacturing standards? So 3D printing is actually a additive process, not a subtractive process. So historically, products have been made by removing material from bars or chunks of metal or plastic, where in 3D printing, what you're doing is actually building something up and not taking away from it. So this is a key point. This is something that I thought about a lot when I first really looked at 3D printing and getting involved, is you are creating a metal or a plastic or the biologic is actually what you're doing. So it's very, very different, and I think it becomes incumbent on the companies to really understand that and make sure they understand what they're making and the actual raw materials that are being used, because it will vary greatly from what you're buying in your current specs. So currently manufacturing or in orthopedic implants, it's metal, it's different polymers, there's ceramics, and there's biologics. Where, you know, and those come in different forms, chunks, or pieces. And how do we then improve those characteristics? And I believe that 3D printing will allow us to do that. And science and data does matter here. So when you're creating the structure, you know, what are you looking for? You're looking for chemically inert products. You're looking for a bioactive action to be taking place. You're looking for something that is strong, has a high fatigue resilience, a low elastomeric modulus, so it interconnects good. You don't want things to be corrosive. So it needs, so when you're looking at creating this, creating your product, you really need to think about that, because corrosion does happen a lot in the body, as all of you orthopedic experts know. You also need good imaging characteristics in it for it to be relatively inexpensive. So why, one of the things I think about is, why are we now going back to metal when metal was in spine was a prevalence? Then everything went away from metal. Now we're coming back to metal. So have we learned that maybe some of the other materials work well, but not optimal? You know, you think about Wolff's Law and the compression, but what do you need for that compression to work? You need a strong scaffolding. You need something that interacts with the body to allow the cells to attach and proliferate. And when you look at that, it's important to understand that you're not just printing something or creating something with holes. You have to, or should be, taking, and you know, this is also for the doctors when they're looking at these technologies, to understand the structural scaffold that is built into the product. And we have seen, unfortunately, already some of the challenges or issues in 3D printing, where you've had devices fail as they're being put in because they're not robust enough to take the insertion forces. And you've seen some products recall because of that. So you look at this interconnectivity of the pores, you look at the modulus of elasticity, but then you also need to build in structural integrity for that product. So is we've learned in the science, it is pore size and the degree of interconnection of those pore sizes. And if you look at a segment of trabecular bone, it's all different holes, all different sizes, but you need to look at that. And, you know, referring back to Chris's presentation about the Wild West in robotics, 3D printing is I would define as the wild west right now, where everybody's rushing to create something. And we all have to remember, at the end of the day, it's someone's mother, brother, sister, father, you know, that we're putting a product into. So the importance of the front end understanding of the metal that you're creating, and what are those properties, and how will that interact with the human tissue over a long period of time. Because remember, we're going for a fusion here with these products, or attachment to bone. So it's a long-term scenario and will be in the body for a long term. So it's not just, hey, I have a 3D printed product. There should be the science to back up of the design, the materials, and the understanding of what you're trying to achieve.
Terrific, John. So again, it all comes back to data, doesn't it?
Yep.
Wonderful, wonderful. That is a terrific presentation. Thank you, John. We have had a lot of interest from our attendees, and I have a question here, and I'm going to send this first to you, Earl, and then you, John. Do you see pricing pressures on devices increasing or decreasing due to the pandemic? Earl?
We haven't seen any pricing pressures due to the pandemic. We had a reimbursement challenge at the beginning of the year, and we saw minimal compression there. But I think that right now, I think our prices will hold from my 2 or 3% decline in price that we had at the very beginning of the year. We're obviously more concerned about procedure volume.
Great, thanks, John.
Well, we've seen similar pricing compression, and if I was a large purchasing organization, I would absolutely be using this as a way to push down pricing even further. Hopefully they won't do it, and it won't be so much, but I think once we come out of this, that we will see that occurring.
Okay, I have a question now. Again, I'd like to throw this to Chris, and make sure you unmute, and also to Earl. When is it appropriate to speak to surgeons about your product and or your service, given what's happening in our country and around the world?
Yeah, I think you have to be prepared, as we talked about in the beginning of this talk. When does the wave end? That during that wave, be it July, be it August, September, both surgeons and the administrators are going to be hyper-focused on the current operations of the pandemic, and then the repercussions of those heightened operations. So I know myself personally, when I'm hyper-focused on something, you get distracted by something you feel is like, not now, you get annoyed. So try not to annoy them, at this point. I'm not saying you go away and hide. Be supportive, volunteer, do something, when the time is right, to endear yourself and to show that you care about more than just your specific widget. So that's my guidance, but I think it's probably going to be the end of 2020 before you start selling.
All right, Earl?
Yeah, my guidance is we should always be talking to our customers. We shouldn't be pestering them. I agree with what we just said, but we should be in dialogue with them. They're in exactly the same boat that we are. Many of these people have had their procedures dry up. It's not just our product that dried up, it's their procedure, it's their livelihood. They've reverted to telemedicine and things like that. So I think we mostly just want to understand the situation of our customers, be empathetic, and try to be as helpful as possible, which is different than having full court press on selling activities. That will come later.
Yeah, I'll say on my end, I am talking to surgeons more today than I ever have. I had, even before our call started, I had 3 calls with surgeons beginning at 5 a.m. my time. And tomorrow I have 6 calls with surgeons. Virtually every one of them is saying, I'm twiddling my thumbs. I'm trying to figure out what to do next. And my advice to every surgeon, put out the "we're open for business" sign. One guy I know out of Delaware went on the local radio station, broadcast to everybody saying, we are here for you. If you need help, can't do surgery, but I can see you. We can do telemedicine, whatever. So I actually, that's why I set up these master classes. We're going to do 3 more in April. We're going to set up a mechanism to get to the surgeon so you can get to them. And I'd say flood the zone, guys, is my personal opinion. But that's because I'm in the communication business. So, of course, I will look at every problem as a communication problem. I understand. All right. Next question. Yeah, Earl, go ahead. It looks like you want to say something.
No, I don't.
Okay. Next question. Robin, in the absence of a vaccine, what is the risk of a second or third wave? Well, pretty much 100%. The next waves are going to be less than this wave. There will be vaccine. There's about 20 in the pipeline. I'm pretty confident we're going to have a kind of a market basket of approaches that pretty much all the providers are going to agree on before the end of this year. These will be existing therapies. Could be a mix of Theraflu and this, Theraflu and this and this and this. That is going to happen. Next year is when I think more formal through the FDA approaches come out. Will medical, Chris, this is a question for you. Make sure you unmute. Will medical schools keep up with training on robotics?
Yeah, I definitely think that'll continue. I mean, in the near term, it's going to be stunted, as they focus on other things. But going forward, we've had the discussions on data, and still to this day, most of the data comes from academia. So this is a chance for them to start out with the robotic approaches and gain the data necessary that comes with later reimbursement and clearances from the payers. So I definitely believe that they'll continue going, and it will probably increase as the next decade goes.
Great, thank you. This is a question for you, John. Do you think ASC elective procedures will recover sooner than July? What are the limiting factors for outpatient elective procedures?
Well, I think the patient, first of all, is a limiting factor, because what I've been hearing is that at some of the ASCs, the surgeries are being really canceled by the patient, not wanting to go into a facility. Other surgeons that I know who own their own ASCs have put in very strict policies of people entering the ASC. It really only has to be the patient in for surgery. I foresee probably in June, starting to pick up in the ASCs, but I also anticipate that in this April timeframe especially, and into May, as there's still the PPE shortages, that hospitals who are part owners in the facilities will start pulling that back and not allowing them to do not immediate need surgery. I mean, so the question becomes, what's elective and what's not. And when someone, is in serious pain and they're having massive motor deficit where they need to have surgery, that will be done in the ASCs. And unfortunately, if this issue continues to spread into other areas, I could see, similar to what happened in New York City with Presbyterian and HSS, where Presbyterian essentially shut down hospital for special surgery so they could send the less sick patients there to be cared for. So the more aggressive patients who need the real caring are in the main hospital. So I could foresee for a long time, especially in New York, that the ASCs are kind of going to be there dealing with the non-corona type patients.
That's a great answer. Thank you, John. Yeah, one of my calls this morning was with a large joint surgeon in the Midwest. He did 3 cases this week, but they were all, one was a patient developed an infection. They were all very urgent type cases, and he said, "Look, we're going one day at a time," and he's just wants to keep his people. He's worried about his practice income, like we all are. So it's interesting. Okay. Let's see here. Oh, hang on a second here. There was a great question I just went past. This is for Glenn. Glenn, infection is often called the last unsolved problem in orthopedics. Assuming that COVID-19 will have an impact on this, do you think the FDA will accelerate the clearance pathway for a true nano-textured surfaces and nano-silver enhanced implants which show promise as both antimicrobials and antiviral on implant surfaces?
Well, that would be great, wouldn't it? I think in general, the FDA is already starting to become more flexible on antimicrobials and other coatings that have an impact on bacteria. We have a lot of clients in this space that are going through, I wouldn't say an expedited program by any means, but certainly the level of data being required is so minimal compared to 5 years ago when the FDA was requiring 3,000 patient studies to show a difference in infection. When the infection rate's already 3-4%, showing a difference is going to take a monster amount of patients. Now they're no longer looking at that particular endpoint. So they're already starting to show a level of flexibility, and I think that's going to increase, especially with the environment of today. And if you can show an impact, not only on the normal run of bacteria, but viral possibilities, then certainly they're going to look at that a little differently. If there is an opportunity or a technology out there being able to show that difference, then certainly approaching the FDA, showing them the data that shows that promise, and then pushing and being more aggressive with the regulatory approach.
Terrific. That's wonderful.
Could I ask a question,
yes.
Follow up
Yes.
to that real quick, Robin?
Yes.
So in Europe and outside the United States, single packed sterile implants are really the trend of where everybody's going. Do you see that, Glenn, or others, and maybe Scott also, of hospitals now forcing more of that, or regulations changing for that?
I mean, from the regulatory perspective, we're not seeing huge trends. I think the FDA has increased their scrutiny on instruments, on biocompatibility, on materials, on a number of different levels that are causing a ton of headaches for clients and companies. So people are trying to figure out, put the implant itself aside, what is the most simple, safest, easiest way to get everything else that's packaged with that particular product onto the market. I think also with the implementation of the MDR in Europe, we're going to see an amalgamation of everything going the same exact route. The level of data, the information, the influence of FDA on the EU, and the data required is already starting to show. So I think we're going to see everything sort of coming together and having the same process across the globe.
Terrific. That's wonderful. We have a request here for Scott. Scott, several of our panelists or several of the attendees would like to have a copy of your slides. Is there a way they could get those from you? And if so, how?
Yeah, so we typically don't send out our slides. In some cases, some of the data that's in the slides is not mine to own to send out. If people want to engage and have a conversation about what all of this and other things mean to their business or their practice, feel free to reach out to me. You can find me on the internet. Our business is Bruder. I don't mean to be an advertisement. Our business is bruderconsulting.com. So you can find us there, and if you've got issues, I'm happy to talk you through it.
Wonderful. That's just fine. Okay. One of our attendees said that he's. What are our collective thoughts? All the panelists. What are our collective thoughts about fundraising and M&A activity for startups over the next 6 months? Any suggestions or strategies? And actually, I am going to kick this over to Earl first, since you, Earl, I think are the master at this. So Earl, what suggestions do you have on strategies for companies who need financing to survive? And then of course, John, you got to chime in, brother, after this. Earl?
Well, I just think it's really hard. Is that enough of an answer?
No, sorry.
Okay. How about this? I think that the VCs right now are going to focus first and foremost on their own portfolio companies to make sure that they're shored up, and hopefully they won't have to make some difficult decisions about letting an underperforming one go and fund more to the other. But I think that it just makes sense that in this time of uncertainty, it's going to slow down fundraising. There's no doubt about it. But I do think that there is a fair amount of venture capital and private equity money that is looking to be deployed. These people are in the business of writing checks, and I think they want to do that. But I think common sense and a little bit of inside information that I have is that this is going to slow down probably in a parallel pathway with the procedure volumes that you spoke out at the beginning of this.
Terrific. John, what are your thoughts?
I agree with Earl. I mean, I would, if you're a new company trying to start right now, the probability of getting funded, if you don't already have large investors with you, is going to be very, very, very difficult in these next few months. So it's about how do you survive or wait it out. I think you will see, as this kind of starts going away, a very robust deployment of capital into the healthcare industry across many platforms. And especially, there are a number of companies out there that we know of who are working on antimicrobials and different infection type controls, and those companies are probably in a pretty good position. Now, I'm not saying the valuations, because I also think that this will reset valuations, that they're not going to be chasing or paying high valuations. They're going to use this, and especially after once there's clarity, kind of what I said about the hospitals with pricing, they're going to use it because they can. So, there's not going to be very many up rounds or valuations that people will be excited about.
Robin, I have two other comments
Scott.
on this.
Yep.
Thank you. First of all, for companies that are either just on the other side or coming out of the valley of death in their funding, those companies, I think, are going to be positioned optimally, because given what the lack of availability of other funding to get companies from that earlier stage through the valley of death, that makes those that are beyond the valley of death even that much more attractive at this point. So if you're there, although the big box companies may have less capital to deploy to purchase you, you're in a pretty good seat relative to the other companies. And the other point that I'd make is that, and I advise this all the time, even more so now, there are sources of non-dilutive funding that can be extremely helpful through DoD, through DARPA, and other avenues. And we know companies who have raised $20 million in non-dilutive funding. And if you're not already working that angle, I encourage, and you're an early stage company, I encourage you to do that.
Scott, that's terrific advice. We just did a profile of a gentleman who raised $9 million from DoD, and I see, and he's an Afghan vet, and as an engineer, went through West Point, and I think that class, that generation of up and coming executives who have those kinds of life experiences, they're tapping some of these non-dilutive approaches, and they are there. And you know what? That's a great advice, Scott. That is just really terrific.
And that was a very nice, I know who you're talking about. That was a very nice profile. I've given him the same.
He deserves it. He deserves it.
Yeah.
Okay, we have one final question, and then just we'll wrap it up. Do we think this pandemic is going to force consolidation of companies or physician practices? We clearly, COVID-19 is putting a stress test on every body, every company, this whole industry. Will this shake out the weaker players? Will it force consolidation? Actually, Chris, may I throw that kind of hot potato in your lap and get your thoughts, and then let's come back around. In fact, if you don't mind, Scott, I'll pick on you to tackle that also. Chris, what are your thoughts?
Yeah, well, definitely anytime you have a stressor to a situation, the weaker ones get flushed out, whatever it may be, pandemic or not. So I do think that opens up, there's not going to be a lot of hope in these entities, whether it's a practice, whether it's a company, and they're going to be more open to, as John said, maybe some exits at a different level of valuation that they thought of prior, so, and I think when you're talking about from the raising funds, it depends on, what the strategics or the larger entities have, but also if it's at the right price and you have a service, a product or entity that fits into their strategic path even over the next 10 years, that's a potential for an exit there. Again, the valuation is going to be lower. So maybe you had a dream of so many zeros, it's not going to be that many zeros. But so I do think there will be some consolidation. Do I think it's a massive wave? No. And I think we'll have to see how much of this federal package comes out that kind of buoys some that maybe would have gone under without it. So.
Right, absolutely. Scott, your thoughts?
Yeah. So I'm sort of piling on with Chris. It's hard to add a whole lot to that, except to say, the larger companies who are otherwise equipped to be making these acquisitions, some of them, you just look in the market, they're getting killed right now. Stryker's down 40%, everybody's down. And so as you think about their rebound, are they going to be focused on delivering and executing on the things that are already in their bailiwick that they have to get right? Or are they going to be focused on acquiring new businesses? I think it's going to be more the former than the latter, except for that company that has really left the valley of death, has an approval or is about to get an approval and bring something novel to the portfolio of the acquiring company. The last thing I'll say is, like Chris, those companies that are on the earlier side that may be looking at, $50 million for an exit, they may have to be looking at $20 million for an exit. And there are going to be some deals tried to be found here.
Well, I'll just point out, in 2008, I bought Johnson & Johnson. It tripled. I just want to put it out there. When valuations get low,
buying opportunity.
I think someone once said, buy low, sell high. I don't know, something like that.
Well,
listen,
Robin,
guys,
to
John,
that last question, though, also, I'm not sure how much consolidation that we'll see from healthy companies to unhealthy companies. And I think the unhealthy companies, or the products that, or the companies that are very me too, and just kind of out there, there's no differentiation or specialness of it, are going to have a hard time. And I could foresee, you know, some unhealthy companies combining, trying to make, you know, -1, -1, a +2, but that's not going to work very well.
Yeah, that's right.
So I see a lot of smaller companies out there not surviving this, especially if we start running into a June, July timeframe.
Yeah, I agree. Okay. I'm going to close it up with some parting comments. And obviously, the very first one is to thank each and every member of the panel. Each of you was magnificent. We had over about 350 attendees. I think this was a really remarkable discussion. And I will close with this wrap up. And also, by the way, this is recorded, and stay tuned. I suspect it'll be available, I hope, in some way or other. Let me wrap up with this. We are in an industry, despite the stress test, that remains innovative. And as you can tell with the discussion today, even after this runs its course, which it will, surgeons will continue to move towards innovative products that deliver more reliable outcomes, safer outcomes, more reproducible outcomes, and push the envelope in terms of patient satisfaction. That's not going to stop. This pandemic, obviously, it's a stressful time, but as you can tell, whether it's robotics, regenerative medicine, whether it's looking at different ways of thinking about MIS, new ways of making a product, i.e. additive manufacturing, that's not stopping. That will continue. So thank you all. Thank you to every attendee and the panelists. Everybody, go get them. Don't back down. Go forward and make a difference. Thank you, everyone.
Thank you.
Thank you.